Okay, so now moving on to the aortic valve. So a quick look at how we should look at it, especially in terms of intra and post. So just a very brief outlook of these guidelines and what they tell us and what are these parameters. It's so confusing sometimes because there are some multitude of parameters. So this is the ACC. So what does the ACC tell us? Jet width is important, vena contracta is important, holodiastolic flow reversal, and also the regurgitant volume and fraction and the EROA. So the first three are reasonably okay, but it is the last three which are a real challenge and which most of the times we don't do it. Now, what are the numbers you have to remember when a patient has got severe AR and you are looking at whether this patient should go for surgery when the patient is especially asymptomatic? So one is the EF. So an EF of 55% is the cutoff, and the other one is looking at the left ventricular end systolic diameter of 50 millimeters. And if you are going to square it, it'll be 25 millimeters. So this is the number which you should be aware of. When it comes to the ESC and the EACVI, they have a slightly sort of, more or less the same, but slightly different. So here they talk about jet area, not jet width. So they have a different sort of perspective. And when it comes to the diastolic flow reversal, while the ACC says abdominal aorta, these they don't mention much about this. It's whether it is the descending thoracic or abdominal aorta, we're not sure. And the regurgitant volume is mentioned, but no regurgitant fraction. So this is an area which still has some, issues as which one. Now, as far as the AAC is concerned, it gives a full spectrum. So it's up to us to choose from this. And you can see that it is divided into qualitative, it is divided into semi-quantitative and quantitative. So most of the times we do the qualitative, and then the semi-quantitative is the one which sort of, more sort of accurate. And these are the ones which we sort of put into the report. And quantitative parameters, despite the fact that it is given so much of importance and it is pushed, I don't think that we do it on a large scale. So I think it's just to sort of, enough to focus on the vena contracta. But if you definitely want to take a step further, there's nothing holding you back. And please go ahead and do the regurgitant volume fraction and the EROA. And there are some limitations. You should be careful. So the display just like any measurement. So when it comes to the LV size, severe AR, LV size is going to be big, but just because it is big, it doesn't mean that it is going to be severe AR. Could it be due to some other reason? So enlargement. So you have to be careful. So when you're looking at the jet width or jet area, so you have to be careful. You can't do it for eccentric jets, and so is the vena contracta. You cannot do it for multiple AR jets and eccentric jets. So you have to be careful. And PISA, it is limited. So again, feasibility, it's again difficult, but there is validation. So I can't really say you shouldn't do it, or because it is definitely sort of included in the algorithm. And when it comes to the flow quantitation, that means the volumetric methods not valid for when you have MR and AR, you cannot do it. And the PHT has got its own issues, so it is qualitative. And then again, the diastolic flow reversal, especially be careful in elderly people where you have a stiff aorta, you might overread it. So be careful about it. But otherwise, it's a good parameter. Now, these are the numbers which I showed you. So I will sort of move on. So this is an algorithm which is there. So again, you can see that in terms of when is the cutoff. So it is 55 for aneurysmal aorta, but when it is Marfan's, it is 45. And when in the presence of bicuspid with additional risk factors, it is around 50. So it is only those who are less than 45, 40, 45, those are the ones which we are not very sure of. Now, peri-op. So what are the parameters you're looking at? So long axis, short axis, and the 5 chamber, these are the views you should be looking at. Deep transgastric especially are great views, so go for it. And look at the mechanism. So is there a problem with the leaflet, aortic root? And look at the etiology. Is it acute, chronic, severity, severe or not? And then intervention in terms of whether a replacement is being made or a repair is being made. Next, cause for the AR. A few examples. Is it an aneurysm like this, an aortic root aneurysm? Or is it a dissection? Or is it something to do with the leaflets? So these are sort of quick see-throughs you have to look at. And then character of the jet. Is it eccentric? That means that, there is some problem with the coaptation, and then it becomes a problem in terms of quantitation. And then when it comes to quantification itself, as I told you, vena contracta, so zoom it as much as you can, and then, go frame by frame and look at the jet width, vena contracta. You get both of them together. One is at the narrowest part and the other one is in the LVOT. And then the other part is looking at the quantification in terms of jet area. So you can, with the 3D probe, you can actually sort of, if you have a good view, you can simultaneously look at the long axis as well as the short axis, and you can get the jet area very nicely. So you can see that there's a very large effective regurgitant orifice area. And to some extent, this itself is enough to tell you that it's quite a big jet here. And then the 3D also, it can be helpful, can be useful, but again, what are the numbers? We're still not sure. So there is no sort of agreement on it, but you can still sort of use it to support your other parameters. Then the surgery is done and you're looking at the valve. So what are you going to look at? You're going to look at processes stability. You're going to look at root hematoma. They'll be looking very bright, shiny. So that means that there is a hematoma forming there. Is there a paravalve leak? Is there a Gerbodes? This can happen now and then. And use as many views as possible. And also remember, the right coronary artery can be frequently affected during the AVR. So you have to be very sort of careful about the RCA and also look at the RV ischemia especially. And you also look at these washing jets. They are coming from outside within the ring, sorry. And then these are low velocity flows, and they're typically washing jets. And when you see a very eccentric jet, you can see that one eccentric jet actually is crossing perpendicular. So those are the paravalvular leaks which are there. So anytime you see a very eccentric jet, a little bit of turbulence, that means that it is a paravalvular leak. And this especially you'll have to be looking at when you have complex aortic root issues. So, in terms of aortic root repairs, and then also you're going to look at the aortomitral fibrosa in terms of infective endocarditis. And then again, you can see a paravalvular leak over there. So these are again areas where you have to be very careful, eccentric jets. And this is an example of looking at bioprosthetic valve. And then even more complex, you have a Marfan's where this is a Bentol. So you'll see a conduit over there. And then also the bileaflet valve you can see over there. So this again, looking at the leaflets and the conduit. And then sometimes things can go wrong and you're going to correct the surgeon, bring the attention, and then there's a large paravalvular leak. So this was very sort of immediately after the surgery, and then you tell them to redo it, and then they go about doing it. So this was a case of aortic root issues and they had to redo it. And patient comes out and then is in the post-op ward. So what are you going to look at? The first and foremost is usually it is going to be the pericardial effusion tamponade. So this is an example of hematoma. So this is a big hematoma which is compressing the RV, and you can see that the normal contour of the RV is lost, and immediately this patient was taken for re-exploration there. And this is an example of tamponade. So again, there is a small hematoma which is compressing. So typically always you go looking for the right side contour. So most of the times you'll see the compression there. Anytime you see a loss of contour, you know that there is some problem over there. So this is an example of tamponade immediate AVR over there. And this is a patient who got discharged and then over a period of time developed pericardial effusion, came with symptoms of tamponade. So things can happen. So at least for 1.5 months, you need to keep monitoring them. And then paravalvular leak immediately can happen. So these are small jets. You don't have to worry about it unless they start to hemolyze. So these generally sort of clear up over a period of time. And the other important area you have to look at is the LV function. You can see that sometimes LV function drops drastically, especially when these patients, when they are taken sort of beyond the time when they should have been operated. So this is coming a little late. So expect the LV function to drop also. And you can also use the strain itself. So this is an example of how strain can be helpful. So the upper one shows a GLS of around 17, but the EF was around 50, 55. Post also was similarly, but when you do the GLS, you know that the LV function has dropped drastically. So GLS can be helpful to look at subclinical dysfunction. And just a few more slides before I close. And you have these patients sometimes coming after, within 1 or 2 years when the aortic aneurysm, they will have a dilated aorta, but they would not have been operated for that. And these people can suddenly have an acceleration where they can have an aortic aneurysm and also sometimes dissection also. These are the unfortunate ones who develop dissection and aneurysm, and they again have to go for a redo here. So to conclude, TE plays a big role in the peri-operative assessment of AVR. For AR, And TT is especially useful during post-op, and anytime during the post-op, if the window is not good, use the T as much as possible and keep a close watch on the new valve and also the aorta, and look at all the spectrum of the post-op abnormalities that can happen. So that would be all. Thank you very much.